Bismillah ar-Rahman ar-Rahim. I am Professor Ahmed Zaid, Professor of Internal Medicine, Hepatopancreatico-Biliary Unit, Internal Medicine Department, Alexandria Faculty of Medicine. Today, I will present clinical approach to ascites, a case study. Actually, in your curriculum of lectures for undergraduate students, you have a lecture presented by Professor Huda Al-Aggan titled Ascites, Spontaneous Bacterial Peritonitis and Hepatorenal Syndrome. Today we will discuss what is the clinical approach for a patient with ascites. And in clinical approach and in clinical scenario in general, you have to have key points in the problem that will be presented for you. The key points are very important for you. The key points are included in history taking, in clinical examination, laboratory investigations, imaging, and so on. Thereafter, after studying these key points very well, you can reach a differential diagnosis and you will have a proper approach for diagnosis of your patient. Let's go to our case study today. Our patient is 50 years old male patient presented with recent history of vague abdominal pain and low-grade fever. He had long history of chronic liver disease due to HCV infection. On clinical examination, the patient was fully conscious and oriented with fever, 37.8 degrees centigrade. He has jaundice, spider nevi, splenomegaly, and moderate ascites. This is the history and the clinical examination. Investigation of our patient, including liver test profile, revealed ALT 58 international unit. The upper limit of normal is 50. AST 72. Upper limit is 40. Serum bilirubin is 4.3 milligram per deciliter. Upper limit is 1. Direct bilirubin 2.9. Alkaline phosphatase 15 international unit and normally up to 13. Serum albumin 2.4 gram per deciliter. The normal range for albumin is 3.5 to 5 gram per deciliter, 5.5. INR international normalized ratio is 1.9. Normally it is up to 1.1. Abdominal ultrasound for this patient revealed nodular liver surface with coarse echo pattern and a focal lesion, dilated portal vein, normal intra and extra hepatic bile ducts, splenomegaly, and ascites. For this patient, abdominal paracentesis was done and revealed a straw-colored ascitic fluid with albumin level of 1.6 gram per deciliter. So, if you revised these two slides, which included the history taking and the clinical examination, then followed by laboratory investigations and imaging, you will find some data, and of course, you will search for other data to help you to reach the differential diagnosis or the provisional diagnosis of your patient. Here we have some questions about this patient. Question number 1. What are other important points in history taking and clinical examination that you have to search for and focus? Question number 2. What's your interpretation for the existent laboratory data and what are other laboratory tests needed for this patient? Question number 3. Mention 2 possible etiologies of his ascites. 4. What is the clinical diagnosis of this patient? 5. What is the differential diagnosis of this focal hepatic lesion? And the next few slides, we will try to answer these questions together. What are other important points in history taking and on clinical examination? If we referred back to the history which presented in the first slide, we will find the patient suffered mainly, his symptoms was abdominal pain and fever. These are the two main symptoms of our patient. Regarding abdominal pain, we have to know, but of course we know now that our patient has two main symptoms, which is vague abdominal pain and fever. However, our patient has long history of chronic liver disease, and this chronic liver disease is probably related to HCV infection. So if we go to the abdominal pain, if you have any patient suffering from abdominal pain, you of course have a differential diagnosis for this abdominal pain. And here you have to focus on causes of abdominal pain in a patient with chronic liver disease. For example, liver cirrhosis. Again, to revise, what are chronic liver disease? You will find the chronic liver disease include chronic hepatitis and liver cirrhosis, whether compensated or decompensated cirrhosis, uncomplicated or complicated cirrhosis. So, what are the causes of abdominal pain in a patient with cirrhosis? At first, abdominal pain may occur in a patient, for example, with acute hepatitis. Here it is not an acute condition. It can happen in a patient with chronic hepatitis, but it is usually dull aching pain in the right hypochondrium. It can also occur in a patient with liver cirrhosis due to other causes. For example, portal vein thrombosis. But in patient with portal vein thrombosis, usually you have severe abdominal pain. It is usually right upper quadrant pain and may and the patient may present with a case of acute abdomen. This is portal vein thrombosis. Other possible etiologies for abdominal pain is, for example, Budd-Chiari syndrome, which is hepatic venous outflow obstruction. And in a patient with Budd-Chiari syndrome, the patient usually is a young age, usually female, presenting in the young age, as I said, presenting usually with right upper quadrant pain, ascites, and bilateral lower limb edema. It's not the condition in our patient here. Therefore, if you have a patient, you may have a patient with liver cirrhosis, for example, and ascites, as in our patient, which has been submitted for any bacterial infection and may lead to abdominal pain. I think our patient is not matching with chronic hepatitis and not matching with portal vein thrombosis, Budd-Chiari syndrome, but in the presence of infection in fever 37 degrees centigrade and fever, I think we have to think of bacterial infection. The second is symptoms of possible causes of infection that you have to search for. In any patient with chronic liver disease and liver cirrhosis, there are common causes and the common sites for infection. The most common is the peritoneum, which is spontaneous bacterial peritonitis. Second is urinary tract infection. We know that urinary tract infection usually comes by gram-negative microorganisms, which may lead to bacterial endotoxemia and bacterial translocation, leading to abdominal pain and maybe cholestasis. The third common site for infection in a patient with cirrhosis is the biliary tract, which is cholangitis. So infection in the peritoneum, bacterial peritonitis, in the urinary tract, cholangitis are possible causes of infection. Here we have to ask our patient about the Charcot triad for cholangitis, symptoms of urinary tract infection like dysuria and so on. And also our patient may have infection in other systems elsewhere, for example, bronchitis, pneumonia, chest infection, and so on. Then our patient has HCV infection with long history, but he didn't give us in the history what about HCV infection. Did the patient receive treatment or he didn't receive treatment? Sure, we have to ask about viral kinetics, which is hepatitis C virus RNA, and if he previously received any treatment like interferon in the era of interferon in the past before the year of 2014, or the recently approved the directly acting antiviral drugs. Also, here we have a common cause for his chronic liver disease, which is HCV infection. But also we have to search and ask for other possible causes of chronic liver disease. For example, hepatitis B viral infection, alcohol intake, and if he has any history of intake of immune suppressive drugs, for example, for autoimmune liver disease. Then we have to ask about other symptoms of chronic liver disease. In this patient, the symptoms which were presented related to the chronic liver disease were spider nevi, splenomegaly, and ascites. These are the features of chronic liver disease, but also we have to ask about other symptoms including lower limb edema or lower limb swelling, bleeding tendency as gum bleeding or epistaxis, and previous GIT bleeding, including melena. Here we have too many points in the history that we have to focus on that will, of course, help us in the approach for diagnosis. Regarding the clinical examination in this patient, in the general examination, you have to focus on features of chronic hepatocyte dysfunction like fetal hepaticus, palmar erythema, flabby tremors, gynecomastia, and lower limb edema. Regarding fetal hepaticus, it's a sweetish fecal odor of the breath in a patient with liver disease. It may happen in a patient with acute liver disease, including acute liver failure. However, in this situation, it is of poor prognosis, and usually the patient mortality rate is very high. However, in a patient with chronic liver disease, fetal hepaticus usually indicates the presence of extensive portosystemic collaterals or severe hepatocyte dysfunction leading to fetal hepaticus. Palmar erythema, which is redness in the thenar and hypothenar eminences together with the finger bases with the central whiteness or pallor, and maybe the finger bulbs. Usually it occurs in a patient with chronic liver disease, and it usually indicates the presence of hyperestrogenemia, and one of the theories trying to explain what is the etiology of palmar erythema. Flabby tremors. Flabby tremors in which the patient cannot maintain the posture of outstretched hands, and it can be a manifestation of hepatic encephalopathy. Gynecomastia. The gynecomastia is enlarged, firm discoid swelling of the male breast, usually explained also by the presence of hyperestrogenemia in male. Lower limb edema, it is usually bilateral lower limb edema, and it is usually soft petting edema. Regarding the local examination of our patient, you have to search for abdominal collaterals in the inspection, and on clinical examination, of course, you will examine by palpation the liver, the spleen, the kidneys. You will complete the examination. Specifically on examination of the liver, you have to focus on the border of the liver, whether it is sharp or rounded, the consistency of the liver, soft, firm, or hard, tenderness. Why? Because in order to diagnose a patient with liver cirrhosis clinically, you have to have a liver with a sharp border, firm in consistency, and it can be either enlarged size, normal size, or shrunken liver. Regarding the spleen as well, of course, you will detect the upper pool of the spleen, the lower pool, and you will examine the spleen and give a full comment on the size of the spleen, the splenic notch, whether it is felt or not, consistency, tenderness, surface, and so on. All these findings are very important for us to complete our data about our patient. Now we came to the second question in our case scenario. What is your interpretation for laboratory data, and what are other laboratory tests needed for this patient? First, we have to interpret what are the findings here. Number one, AST, ALT, both are elevated. However, the AST-ALT ratio is more than 1. Usually it is less than 1, but it can be more than 1 in a patient with liver cirrhosis, Because usually in a patient with chronic hepatitis, for example, hepatitis C related chronic hepatitis, you will find usually both ALT and AST are elevated. However, the ALT is usually higher than the AST. And if the patient process of inflammation progressed and reached a state of cirrhosis, here the ratio will be reversed and the AST will be higher than the ALT. Therefore, the AST-ALT ratio more than 1 indicates the presence of liver cirrhosis in a patient with viral infection. However, it can also occur in other patients without liver cirrhosis, like alcoholic hepatitis or Wilson's disease. Another point in the laboratory data is increased serum bilirubin, mainly direct, and increased alkaline phosphatase. This means that our patient has jaundice, cholestasis, which is a stasis of bile. And here it is most probably intrahepatic cholestasis. Why? Because the patient has biphasic hyperbilirubinemia, both direct and indirect are elevated, but direct is higher than indirect. And then he has elevated alkaline phosphatase, which is minimally elevated alkaline phosphatase, because in extrahepatic cholestasis, usually you have significantly elevated alkaline phosphatase, usually 3 times the upper limit of normal or more. Plus, in ultrasound examination of this patient, he reported that the patient has no intrahepatic bile duct dilatation nor common bile duct dilatation. So we have jaundice, cholestasis, which is most probably intrahepatic cholestasis. Decreased serum albumin and increased INR. We do know that serum albumin and INR are one of the synthetic functions of the hepatocytes. And if you have jeopardized serum albumin by decreased its serum level or increased the INR, this means that your patient has synthetic liver cell dysfunction. SAG, serum ascites albumin gradient. In this patient, it was 0.8. And we have another slide which will discuss what is the importance of SAG now. In this patient, it was 0.8. Other needed laboratory investigations. Now you have your patient with these data. AST-ALT ratio is more than 1. Bilirubin is elevated with alkaline phosphatase, mainly direct. Serum albumin and INR was jeopardized by decreased albumin and increased INR. SAG is less than is 0.28, which is less than 1.1. What do you think about other needed investigations for this patient? Of course, regarding HCV infection, you have to search for the viral kinetics or the viral load, which is hepatitis C virus RNA. And we have to do other laboratory tests to exclude other possible causes of liver cirrhosis. For example, hepatitis B viral infection by doing hepatitis B surface antigen. And if you are suspecting of autoimmune disease, you have to do autoimmune markers like anti-smooth muscle antibody, anti-nuclear, liver kidney microsomal antibody, protein electrophoresis, and of course other causes of chronic liver disease you have to search for if you are suspecting one of these causes. Complete blood count is important in this patient. Why? We have to know what about the hemoglobin level, because one of the causes of low-grade fever is blood loss in the gastrointestinal tract, and blood loss may be presented in the form of occult blood, melena, or massive GI bleeding. But in this patient, usually it is either occult or melena. So hemoglobin is important. Platelet count will give us an idea about how far the severity of liver cirrhosis and if the patient's spleen, enlarged spleen, is associated with hypersplenism or not. But very important to look at white blood cell count, because here you have a patient with infection or possible infection. So you have to search for white blood cell count, especially the neutrophilic count. It is expected to be elevated in a patient with bacterial infection, which is possible in our patient. Urea and creatinine is important because here you have a patient with ascites and possible bacterial infection, and it can be associated with elevated blood urea and serum creatinine because you know that one of the complications of ascites is the occurrence of hepatorenal syndrome. Also, in the ultrasound report of this patient, it has been reported that he has a focal hepatic lesion in a background of coarse echo pattern. And here, of course, the first possibility that will come in mind is occurrence of hepatocellular carcinoma, so alpha-fetoprotein is important. You do know that alpha-fetoprotein is helpful in diagnosis. However, it is only elevated in about 40 to 60% of patients with hepatocellular carcinoma. But if it is elevated, usually you have to carefully look for the occurrence of or the presence of focal hepatic lesions. Regarding ascitic fluid analysis, in this patient, it has been presented only the value of ascitic fluid albumin, which was 1.6 gram per deciliter. But in any patient with ascites, when you are aspirating a sample of the ascitic fluid for analysis, you have to do analysis chemical examination, especially polymorph nuclear leukocyte, because in this patient, if it is elevated more than 250 cell per cubic milliliter, it will be diagnostic for the occurrence of spontaneous bacterial peritonitis. Also, you have to do bacterial examination, including culture sensitivity, of course, and test for acid-fast bacilli to rule out the presence of tuberculous ascites. Pathological examination is mandatory, of course, to assess if this patient has malignant cells or not, especially in the presence of focal hepatic lesion with the possible presence of hepatocellular carcinoma. This is a snapshot slide from the presentation of Professor Hodal again that is present in your hands about the diagnosis of ascites and the importance of SAG. SAG is serum ascites albumin gradient. It is actually the subtraction of ascitic fluid albumin from serum albumin, and a cutoff value of 1.1 gram per deciliter is very important for us. Why? Because it can differentiate high SAG ascites from low SAG ascites. If it is equal or more than 1.1 gram per deciliter, it means that this patient has ascites which is related to portal hypertension. However, if it is less than 1.1 gram per deciliter, it means that the patient has ascites which is due to other causes rather than portal hypertension. So it can differentiate between cirrhotic ascites or portal hypertensive ascites and non-portal hypertensive ascites. This is with a high sensitivity and specificity, and I mean which is high accuracy. However, it is not 100%, of course. In cirrhotic patient with mixed ascites, SAG is high. Again, if you have SAG more than 1.1, it is cirrhotic ascites or portal hypertensive ascites. Less, you have to search for other etiologies, especially malignant and other causes of ascites, as I will tell you very soon. Mention two possible etiologies for ascites in this patient. Actually, these are the causes of ascites. Ascites with normal peritoneum, including portal hypertension. The most important causes of portal hypertension are liver cirrhosis, Budd-Chiari syndrome, veno-occlusive disease, IVC thrombosis, portal vein thrombosis. Cardiac causes, right side heart failure, constrictive pericarditis. Hypoproteinemia by its different causes, nephrotic, protein-losing enteropathy, severe malnutrition. Pancreatic diseases, including pancreatic ascites and pseudocysts. Endocrinal diseases, hypothyroidism, Megi syndrome, ovarian hyperstimulation, and the stroma ovari. Miscellaneous causes like chylous ascites, bilious ascites, and sometimes nephrogenous or urinary ascites. Ascites with diseased peritoneum. The most common is infections, including tuberculous infection, fungal HIV-related Whipple's, and malignant ascites like primary mesothelioma, pseudomyxoma peritonei, hepatocellular carcinoma, massive hepatic infiltrates, and intra-abdominal tumors. And there are other rare causes as well. So, what do you think about the possible causes of ascites in our patient? This is to answer the third question. Of course, here we have many data suggestive of the presence of liver cirrhosis, including history taking, clinical examination, laboratory investigations, and imaging by ultrasound. So the patient may have ascites, which is related to liver cirrhosis. Also, the second possible causes of ascites in this patient is the presence of possible hepatocellular carcinoma and the presence of focal hepatic lesion. So these are the two common causes of ascites in this patient. But what is the most important is the SAG in this patient is I think serum albumin was 2.4 and acetic fluid albumin was 1.6. So SAG in this patient is 0.8. So you have to search for not only simple ascites. So either this patient had bacterial infection in the form of spontaneous bacterial peritonitis, or he had hepatocellular carcinoma inducing malignant ascites. What is spontaneous bacterial peritonitis? In short, it is a life-threatening infection of ascites in the absence of an intra-abdominal source of infection. It is likely to be associated with abdominal parasecondary ascites, likely to be associated with bacterial paracentesis. Spontaneous bacterial peritonitis develops in about 8% of cirrhotic patients with ascites. So it's very important usually to put in mind in the differential diagnosis of any patient suffering from abdominal pain, abdominal tenderness, fever, deterioration of his general condition, or deterioration of his liver test profile, increased bilirubin. These are all could be characteristic features for the occurrence of spontaneous bacterial peritonitis. And also, we have to identify what are the risk factors of spontaneous bacterial peritonitis. In other terms, which patient will be at high risk of developing SBP? Usually these patients are those with acute gastrointestinal bleeding, low total protein concentration in the ascitic fluid, and the previous episode of spontaneous bacterial peritonitis. And nowadays other factors are blamed, like the use of certain drugs, especially proton pump inhibitors. Now, after discussion of our patient, we came to the clinical diagnosis of our patient. What is your clinical diagnosis? Usually, to put a clinical diagnosis for a patient with chronic liver disease like this, you have to comment on the liver, the spleen, whether the patient has jaundice or not, encephalopathy or not, GIT bleeding, whether present or not, ascites, degree of ascites, and whether it is simple ascites or complicated, and if he has other complications like focal hepatic lesion or acute liver failure. Our patient, of course, has liver cirrhosis, which is most probably related to HCV infection, and after other investigations denoting the etiology of other causes of liver disease, we will exclude other mixed causes of liver disease, like other mixed hepatitis B infection, alcohol, and so on. Second, he has splenomegaly, and whether he has hypersplenism or not, it will be clear from the laboratory investigations of complete blood count. And if you are suspecting the presence of hypersplenism, you may need to do bone marrow examination to assess and to prove the diagnosis of hypersplenism. He has jaundice, and as I said, it is intrahepatic cholestasis. From the current available data in this patient, I think there is no evidence of hepatic encephalopathy, but it is important to ask your patient about all symptoms of hepatic encephalopathy, especially very mild symptoms, to rule out the presence of minimal hepatic encephalopathy. What about GIT bleeding? Of course, we will ask our patient whether he has GIT bleeding or not, and we will report whether he is bleeder or non-bleeder, because it will differ in the management of our patient whether he is bleeder or not. Of course, we will do upper GI endoscopy for our patient to reveal the presence of varices, and then we will take the decision whether to do band ligation for these varices or not, according to many circumstances, including whether the patient is bleeder or non-bleeder, whether he has a small size varices or large size varices. Our patient has moderate ascites with query spontaneous bacterial peritonitis. The diagnosis of spontaneous bacterial peritonitis will be confirmed by the presence of elevated polymorphonuclear leukocyte more than 250, with or without the presence of positive culture for bacterial infection, which is usually gram-negative microorganism. Focal hepatic lesion for evaluation. Here we reach it that this patient has a focal hepatic lesion, but we have to evaluate what is the nature of this focal hepatic lesion. What's your differential diagnosis for focal hepatic lesion? In this patient, we have a patient with focal hepatic lesion on a background of liver cirrhosis, which is related to hepatitis C viral infection. So, the first differential diagnosis should be hepatocellular carcinoma till proved otherwise. However, other possible causes should be put in mind. Focal hepatic lesion can be benign lesions including hemangioma, hepatic adenoma, focal nodular hyperplasia, and sometimes cyst. Cystic lesion of the liver are actually so many types, including simple cyst, hydatid cyst, cystic tumors, and so on. Malignant focal hepatic lesion, the most common is hepatocellular carcinoma. The second common primary tumor of the liver is cholangiocarcinoma, and solitary metastasis, of course, is as well after HCC. Rarely you may find rare hepatic tumors, including hepatoblastoma, especially in children, or lymphoma. So this is a differential diagnosis, and as I said, in this patient, hepatocellular carcinoma should be considered till proved otherwise. Then, to diagnose hepatocellular carcinoma, to prove this diagnosis, what do we have to do? We have to do triphasic spiral CT liver, which is the main diagnostic tool for hepatocellular carcinoma. In this diagram in front of you, you will find the liver with its blood supply. We know that the blood supply of the liver is mainly by portal vein and the hepatic artery. The normal liver, in the normal liver, the portal vein carries about 75% of the blood supply of the liver, and the hepatic artery is about 25%. However, if the patient is cirrhotic, here the portal vein blood supply will diminish and the hepatic arterial blood supply will take an upper hand. This is an important fact. The second important fact for hepatocellular carcinoma is it is a hypervascular tumor. And by hypervascular tumor, it is the nature of the pathological features of the tumor. It means that it will take the intravenous contrast properly in the arterial phase and wash it out rapidly in the portal venous and the delayed phases. These are the cornerstones in which diagnosis of hepatocellular carcinoma is based on using triphasic CT and MRI liver. Is that the tumor is dependent mainly on hepatic arterial blood supply. Second, it is a hypervascular tumor in the majority of the tumors. Of course, there is a minority of the tumors of hepatocellular carcinoma, is hypovascular tumors. If you look to this focal hepatic lesion, in the arterial phase, of course, the phases of arterial phase, portal venous phase, early and delayed, can be assessed radiologically on CT examination of our patient. And usually the intravenous contrast is injected in the intravenous line very rapidly in a very short time using an infusion pump to achieve the arterial phase, portal venous phase early and delayed. In the arterial phase, the tumor will take the contrast very well, and then in the portal venous phase, it will wash out very rapidly. Again, here the tumor will take the contrast very well, and in the portal venous phase, it will wash out the contrast. This is a very characteristic, peculiar feature for hepatocellular carcinoma, and there is a scoring system for diagnosis of hepatocellular carcinoma called the LIRAD system, and this LIRAD system can, to a great extent, reach to a final diagnosis of hepatocellular carcinoma, and usually we do not depend on biopsy from the focal lesion to diagnose hepatocellular carcinoma, and we can start management of our patient based on a high quality and good quality triphasic spiral CT if it is diagnostic. This is an example for a patient with a liver cirrhosis. As you see, it's irregular border, sharp, and this is ascites around the liver surface, as you see. And here, this is the arterial phase. How could I know that this is the arterial phase? If you look here, this is the aorta. It's bright. It is taking the contrast. And at the same time, the focal hepatic lesion here is bright as well. This is the arterial phase. However, in the venous phase here, the aorta is not bright. It lost its contrast. And as well, the tumor. It washed out the contrast. So, enhancement of the focal lesion in the arterial phase and wash out in the portal venous phase early and delayed. Of course, with other characteristic radiological features, but this is the main feature. Few words about hepatocellular carcinoma and ascites. The annual incidence of hepatocellular carcinoma and HCV-related cirrhosis is about 4%. Screening for HCC is mandatory for all high-risk patients with liver cirrhosis by regular ultrasound, abdomen, and alpha-fetoprotein. Any patient with focal hepatic lesion on a background of cirrhosis should be considered HCC till proved otherwise, and should be evaluated by triphasic spiral CT liver and possibly by MRI. And in a very minority of patients, if the radiological features are not concluding or confirming the diagnosis, we can do needle biopsy. Ascites in HCC cirrhotic patients can be simple ascites due to the presence of liver cirrhosis, or can be malignant ascites, and here diagnosis will depend on ascitic fluid examination by the SAG less than 1.1 and the presence of malignant cells within the ascitic fluid. In conclusion, from discussion of our patient today, with a clinical scenario of ascites, we came to these conclusions. Detailed history taking, clinical examination, and liver test profile are essential for proper evaluation of patients with ascites. Diagnostic paracentesis with laboratory examination of ascitic fluid is needed for all patients with moderate or severe ascites. SAG, which is serum ascites albumin gradient, SAG value of 1.1 is an important test with high accuracy that can differentiate ascites due to portal hypertension from other causes. I hope that you enjoyed our case today, and thank you for your attention.